Hi, this is Leanne Wendt, and I'm presenting my PowerPoint on practice change simulation at the end of 12-hour nursing shifts. The objectives of my presentation is to appraise research and summarize the knowledge available on 12-hour shifts, to outline a strategic plan for implementation of a practice change in nursing environment, and a description of how implementation of practice change will operate, description of theoretical models that will be used to and how barriers will be overcome, sources of internal data that will be used, and describe evaluation methods of implementation. 12-hour shifts for nurses have been around for a while. And one of the reasons is because managers believe it is a cost-effective way to manage their units. It allows for continuity of care. For example, in a 24-hour period, when you have 12-hour shifts, there's only a total of 2 changeovers rather than 3 on an 8-hour shift. So a lot of the information on a patient won't slip through the cracks, and the continuity of care remains steady. But some nurses prefer longer shifts to allow for more time away from work. In the nursing force, there's a lot of women who work as nurses, although that is changing. And one of the reasons why is they they have more days off to spend with their family. They have more flexible hours for childcare. They only have to get childcare 3 days out of 7 instead of 5. More time with family and friends. Even if they wanted to, they could get another job somewhere else. Opportunity to work overtime shifts is available as well. But there are increasing concerns over the effect of 12-hour shifts on nurses and the quality of care that a patient is receiving. Most nurses actually like the 12-hour shifts, but this presentation will show how maybe it's not the best idea for nurses and patients alike. One of the effects of long 12-hour shifts is nursing fatigue. And I would like to use Elizabeth Jasper as a case to illustrate this. She was a nurse practitioner at a hospital in Ohio, and she had been scheduled for 3 12-hour shifts, but in reality worked over 14-hour days during those 3 days, and in effect worked almost 40 hours in 33 days because she was a specialized nurse and they needed her to help perform procedures. On the way home on the 3rd shift, she fell asleep at the wheel and she careened off of Ohio 50, went airborne, and crashed into a tree. The carnage was so severe that there was no question that the occupant inside was dead. So her family did file a lawsuit against the hospital for making her feel like she needed to work so many hours and allowing her to. So in Nurse Jasper's honor, I did post her picture, but I also wanted to show the wreckage of her car, to make it more real. It's sobering and eye-opening to see what happened to this beautiful person after too many hours on the floor. In the case of patient errors, I'd like to illustrate Redonda Vaught. She became known as the nurse who made a deathly or fatal error on a patient named Charlene Murphy, age 70. Charlene Murphy had come in for a subdural hematoma and was about to undergo a scan, and Nurse Vaught was told to give her some anti-anxiety medication, specifically Versed. As Vaught went to the AccuDose, she punched in the first 2 letters, VE, and grabbed the first medication that came up without checking the right dose, the right drug, the right patient, all of those rights that we're supposed to check, and in fact pulled out a drug called vecuronium, which is a paralytic drug, and it's used during anesthesia and causes paralysis. And so Charlene Murphy's lungs were paralyzed. She couldn't breathe, and her brain became damaged because of lack of oxygen, and she did end up dying 12 hours later, directly related to this medication error. And it turns out Rodanda was also working hard and too many hours on a very busy ER floor. This is Vecuronium. This is Versed. The bottles look very different, but when you pull them up on the AccuDose, you can see how that could happen, especially if you're tired. So research on 12-hour shifts, nurses who work 12-hour shifts over 8-hour shifts made 3 times the amount of medication errors. Increase of bloodborne pathogen exposure, nurses that work 12 hours over 8 hours were increased. And I don't understand why, but specifically during the last 2 hours. Increase in needle sticks on nurses, on those who work 12 hours. 2/3 of the 12-hour shift nurses had an episode of drowsy driving incidents within a 4-week period, and 17% of those nurses had an increase of musculoskeletal disorders, where you can see why they're on their feet that much longer. So you can see how that could happen. Nursing burnout ratios are higher, and patient care satisfaction rates are decreased. Other points are that nurses do report fatigue and exhaustion, and that the limited sleep between the 12-hour shifts is minimal, 5.5 hours. That is not enough rest to come back the next day and put in a grueling 12 hours and be a good nurse. I just don't think that is enough sleep. So these fragmented sleep patterns can lead to many health issues, including migraines and cardiac stress, ulcers, joint disorders, inclination towards addiction and poor eating habits, and anxiety and depression. And then in the end, that is translated to the patient care. You're grumpy with your patients and not as compassionate, in my opinion. So my plan would be to formulate a team to put into place a plan to implement 8-hour shifts with the opportunity to work a 12-hour shift only after 3 8-hour shifts have been worked. And this would be on a trial basis. And so this team would educate staff on the disadvantages of 12-hour nursing shifts. Looks like I made an error there. That staff should be shifts. This team would create enthusiasm and a vision and an environment for change, and they would be in constant communication with the staff via email, WebEds, or even like staff meetings to keep that enthusiasm going. And once this plan had been implemented, the staff could provide feedback anonymously, and so that the team would be open to this feedback and implement change, and then maybe retry. This is based on the Stettler model, which I really love because it's straightforward and simple. Phase 1 is preparation. Phase 2, validation. Phase 3, comparative evaluation and decision making. Phase 4, translation and application. And Phase 5, evaluation. And sources for internal evidence can always be found in the hospital itself through human resources, through patient relations, electronic medical records of the patient, and even governmental statistical websites such as hhs.gov. Here's my references for this presentation, and thank you very much for listening. I think I went a minute over.